Good morning, everybody. Hopefully, you all had a good night. Not too good a night. Welcome to the session we have this morning on DHIS2 in national architecture. It kind of makes it sound very grand, but in fact, we'll be talking very nuts and bolts, basic things. So what are we going to do this morning? First of all, you only have to put up with me for a very short time, 5 minutes. I'm just going to tell you a little bit about the aims of the session, how we've set it up. And then I'm going to introduce you to our esteemed panel. And they are going to each give like a 10 or 15-minute short presentation. We'll put them all up here to give them the opportunity to respond a little bit to one another. And then when we are done, we will open it up for more general discussion and questions. And we hope people don't ask very difficult questions. And that's what we will do. So just a little bit about the panel. They're all here except for Jose, who seemed to have gone the wrong way and missed the station. He's now tearing around in a taxi, but hopefully we'll be here soon. This is who we have. We have Aishat Samia from Maldives. She's the permanent secretary of the Ministry of Health. She's going to tell us a little bit about DHIS2 in context there. We have Dr. Salamatu Nandogma from Ghana, from the Ghana Health Service. Ghana Health Service we've known for a long time. So it'll be really nice to just hear that reflection on how it has been over such a time. I think Maldives is a little bit younger. Then talking of reflections over time, we have Adam. Most of you know Adam, I think. Dr. Adam, let's say. I met Adam as a PhD student, and I don't remember much about. I remember a little bit about your PhD, but I knew it had architecture and standards in it somewhere, and I remembered it's 10 years later, and I've grabbed you for for that. And then we're also very fortunate. I hope. Yes, right on time. Jose, we're down here. We have Jose. Jose, I don't know that surname of yours. What do you do with the X? Is it a like Oza? Or J? Okay. So we have a Jose Costa Teixeira. That sounds nice. Yeah. Yeah. He's joining us, I think, but Jose's from PAF, but he has a half a dozen other hats. And I think he'll talk about some of his hats when he introduces us. Jose is he's the fire expert. And yeah, we hope to pick his brain a little bit this morning and not get too technical. And that's who we have. I think it's a wonderful panel. Thanks all of you for agreeing to attend and getting your slides in and into the folder. Yeah, so I've allowed myself the liberty because I put the session together. I'm allowed to put one slide on myself. A little bit about architecture. What are we talking about? Now, people who know me know that when I talk about architecture, it's sometimes a little bit different to the way other people talk about architecture. People say, show me your architecture, and they'll show you all the boxes with lines and arrows and policy documents and all of that. For me, that's not your architecture. Your architecture is the practice of what your architects do. Right? Architecture is something that that architects do. What you're showing me there is the product of architecture. And so sometimes it's worth bearing in mind there's more than one product of architecture, right? We make this stuff, but we also make knowledge about one of the things architects produce is knowledge about architecture. So that you try something, it doesn't work, you learn, the next thing you try, you have to adjust all the time. You're building knowledge as you go. With architecture in the built environment, people building bridges and blocks of flats and what have you, I think those kind of architects are actually much better at sharing the knowledge. We are just learning that really in information systems, how best to accumulate and share knowledge about architecture. But it's important to know that that's what we are doing. And maybe the most important thing that architects produce is that they change the world. Right? They change the way that people work. They change the way that people get paid or don't get paid. They change everything about our social life is affected by the architecture. If you know that, then you know they're also deliberately producing it. So yeah, you think about architecture as something that architects do, then it does raise the question of who are they doing it for? Who are they? Those are always important questions to ask, particularly from a sort of HISP perspective. And often we get asked to go and work in a particular country. And one of the first things I try to find out is who is doing the architecting here? Who are the people? And of course, who are they doing it for? So I'll just ask you to keep those little thoughts in the back of your mind as we're looking at the very different set of presentations that we're going to see. So the questions I asked the panel to think about as they put their presentations together, and they don't have to address all of it. Maybe some will pick at different parts. Questions concretely, what role is DHIS2 playing in the national plan? I think for us as the DHIS2 community, that's the key question for us. It's not obviously key for everybody else, but what we try to avoid, I guess, is, and we do see it, DHIS2 is there and is doing this, and then there are architects there and they're making plans like this, and these two things don't intersect at all. That's bad for the plan, but it's also bad for the DHIS2 implementation. So how do these things align, if they do or if they don't? And then how things change over time. I think Adam will talk quite a bit about that, if I remember correctly. Question of interoperability and standards always comes up. I mean, as soon as you start putting things together, you start thinking, well, how do they relate to one another and what is in there that could be useful to what is in there? Usually in our domain over the last 10 years at least, well, 5 years more loudly, we've been deafened by fire fetishists, I suppose would be the way I would put it. Everybody's just saying, use fire, use fire, use fire. And we are all kind of trying to understand how best to respond to that and why should we be doing it and what good is it anyway. We're very lucky, as I said, to have Jose here. Hopefully he has some insights there. We look forward to fighting with him a little bit as well. And then governance, I ask people to just talk about some of the aspects of governance. And I think particularly maybe there are panelists from Maldives and Ghana they are actually responsible for systems. I mean, we are not, fortunately. And we might all learn a little bit together. Okay, that's all you have to put up with from me. What we're going to do, I think if we can all just come up and sit, and then I will let you all have a go. Do we have enough chairs? Give this to All right, so yeah, our first speaker, panelist this morning is Aishat Samir from Maldives.
Thank you. Thank you. So my name is Samia. I'm from the Ministry of Health, Maldives. In this session, in my presentation, I would be looking at our journey on utilization of DHIS2, contributing to the overall digital health architecture of Maldives. Let me begin by walking through how DHIS2 is integrated into the different national plans in the Maldives. First, we have a 5-year national health strategic action plan. DHIS2 is a core component of the strategic health action plan. As I go through the presentation, you would know that like main components of digital health is covered through DHIS2. So for this reason, it is in the in our overall 5-year health strategic action plan. This ensures that there's alignment of main policies to support the overall data for decision making in the Maldives. Number 2, in our different plans, UN plans like with WHO, with UNICEF, with UNFPA, there is link with DHIS2, but the focus is different. So with WHO, the focus more is on integrating towards overall public health information system, on scalability, on standardization, on overall sustainability of data for decision making. For UNFPA, it's more on like reproductive health, maternal health, more on like personalized care for this cadre or this group. And to be like adaptive in our care, to be more responsive to the care for these patients. With UNICEF, it's more of like child health, immunization on primary health care. So using or leveraging the different plans we've got nationally to support overall digital health efforts. Number 4 is just touching on one example. So we've got different technical plans. So reproductive, maternal, neonatal, child health, adolescent plan. This also is supported by DHIS2, similar to like the TB plan, the NCD plan. So different technical plans are also aligned, and this is also linked with DHIS2. Again, as I go through the presentation, you would see how the different technical areas are covered or supported by DHIS2. And lastly, the Maldives Digital Health Architecture Blueprint covers or emphasizes DHIS2 as an important component of our journey of working towards the digital health architecture ecosystem. So going through our journey on how we've evolved on the use of DHIS2 over the years, we started in 2019 with a modular-based rollout. So from 2019, it was aggregated data reporting from all levels. So we've connected each level, like island level, group of islands would be like atoll level. So islands feeding data to the atolls, and atolls feeding data to the Ministry of Health. But that was aggregated data. From 2019 up to like 2022, it was aggregated data. And from 2022, we started working on individual patient level tracking of patient data in different modules. So like we've moved into like national individual level patient tracking through DHIS2 for immunization across the country, private, public included, for NCDs. So everybody after the age of 18 years gets the risk factors, gets their like health data captured into the system. This is not rolled out across the country, but this is being rolled out. Lymphatic filariasis, because there was an outbreak. So just to show that There's like quick data entry opportunities through DHIS2 as well. Tuberculosis, maternal health, and it just goes on. But one thing I would like to touch base in our journey is, like, I cannot emphasize how important it is on building local capacity. From our experience in 2019, when we started with aggregated data, we were like totally dependent on external support. But from 2022, like once we started with the individual patient level data tracking, the focus is more, we still have the external support, but the focus is more on like the local capacity building. Countries are different, the capacities are different, but what's critical and what I would like to touch is the local capacity building. So wherever you are, however small, however big, the capacity building for locals are critical as you move forward, because there's a lot of help, there's a lot of changes, there's a need for customization, and if you are to have the users engaged, it's very important that you are able to adapt to the changes. And adaptability comes when you or the locals are able to bring the changes necessary. The public portal development, another key milestone that we've achieved is we've rolled out a public portal in December last year. And the portal actually gives information to the public, to the users. So many a times, like in health sector, we feel information is ours as like policymakers or health developers. But the most important people in a health system are the users. So this component, the public health portal, allows information to be given to the users themselves, and this engages the users. So they are able to use their own information for better decision making, to change their behavior. So this is a very critical component that we have like in our system. And lastly, continuous adaptability and scalability. Like from our experience at the initial stage, when it's difficult to adapt, when we are not able to like meet the needs of the users in a timely manner, we find they just drop the system, like the implementation gets affected. But when you are able to listen, when you are able to connect, when you are able to change the system to the major changes in a controlled manner, it really helps in implementation and bring in or improve in the user acceptability. As we've gone through these different phases, like as we've evolved our use of DHIS2, something we've learned and something we are still working on is the interoperability component. Number one, we have a unique national identification number used in the country. So whatever system we have, we use the same identification number. But the challenge is for foreigners. We're using passport and work permit number, but there's also like unregulated foreigners. So we are using a certain number, a specific number to uniquely identify, but it's an ongoing process. The current, where we are right now, is there's work to integrate with the national identification system and EFA system. EFA system is a system used nationally in the Maldives for like to get access to all the government services. So to get license for social services, for social housing, for economic services, it's the same unique identification that you use. They're also expanding it to foreigners, which helps health sector in the unique identification, and there's automatic data transfer to the health sector in our information systems as well. Number two, cross-sector interoperability. We find that many sectors are working together with health. For example, like education, environment. For us, even like social ministry. What we find is, to give you an example, like in the Maldives, like immunization registry or record is used in children's education enrollment. So what we used to do is, before DHIS2 and the online immunization, national immunization registry, a manual record of the immunization is used by the health facility, but we also have data captured into our information system. But education ministry also have their own information system. So once they received once they received, okay, so once they received the manual cards for immunization, it gets entered into the education ministry system. But with the DHIS2 online national immunization registry, the data is shared between health ministry and education ministry. So it's a lot, less hassle for the parents for like two ministries. Similarly, with the social ministry, because they are very concerned, they want to track data on early identification of like disabilities. From the health sector, like we have a module for early identification of like up to 5 years, we monitor the milestone, developmental milestone and growth monitoring for like each child in the country. And then this supports early identification. And when data gets integrated or shared with the social ministry, they have the information needed to target individuals. So integration, interoperability, like between sectors is critical. It also brings more acceptability nationally to DHIS2. So rather than having DHIS2 as your own system, if you have like more users across sectors, if the public also demands the information, there's acceptability across the country. There's demand for data from DHIS2. Standardization and customization in all of our modules for DHIS2, like we work on the technical bit, technical aspect, there's standardization. So there's technical standardization of technical documentation, but also at the same time, like certain things are similar in each of the modules, like the patient profile is the same. So whenever you move from one module to the other, the same patient, like if they request for a service in another module, the same profile moves to the other module. But certain things we are still working, like fire, which we will hear from Jose more. We are building on our capacity right now. Right now, there are some information that flows between the modules, but there is more work that is happening or that's planned to improve on our interoperability. I would like to touch base on the lessons learned. Number one, start small. So you don't have to like implement everything at the same time. Country context, your capacity is important. So starting small, starting with your priorities and then scaling up, but scaling up smart. Because once you show this works, like immunization registry, once it's rolled out in 1 year, when you have the whole birth cohort of the country, each program demands for implementation, but you can't do everything together. So scaling up smart, and then engagement, local engagement. It's important because it's not only health ministry that's involved. It's also the program, it's also the technical people, it's also the IT people, it's also the technical expert, it's also the UN agencies, because everybody requires data for different purposes. And if you are to have different information system to capture the information that they need, it doesn't work because the users are overburdened. So engagement with all the stakeholders. And lastly, technical partners. You need the technical support. You need to ensure that you have strong technical support so that there are like many pitfalls or many lessons we've learned elsewhere. We do not have to repeat the same mistakes when we go through our journey. Lastly, global learning. So through our journey, we've learned, we've listened, we've been listening to the DHIS2 community. We've got a lot of support in our journey. As you go through DHIS2 rollout, the governance is critical. Very, very critical, very important part to ensure that you know your priorities. So there's always focus on your priorities. Like many a times, there's a lot of like, you get funding to implement a certain module, but you have to start with your priorities. And number two, to ensure that these are aligned with your national plans. So the digital health architecture blueprint covers touch base, is linked and to the DHIS2 as one component, but there are many other components. It's one part of the puzzle in the digital health architecture blueprint. A multi-sectoral steering committee, because DHIS2 not only is linked with the health sector, it also supports UN agencies, it also supports other sectors. So what information we are collecting flows to like other sectors, other systems. So multi-sectoral steering committee who gives the policy priorities, who also ensures that there's alignment with the overall plan, priority plans. Working groups, it's very, very important component. So as we go through like each module, there are like core teams, core working teams for each module. The core working group includes program level staff, technical experts in the IT area as well as like health areas. It includes health information people and health information team as well as program managers. So that there is a timeline, there is a priority, but the most important component is the systems that we build or the modules that we roll out has to be like technically sound, has to be like vetted with the technical teams. They have to be like adaptable to the local context. So when we work with the core teams, we engage them from the very beginning. So from conceptualization through each stage in the development, to implementation, to monitoring, the core teams are there. So like every change gets vetted by the core team so that we know these changes are applicable to the local context before we roll out. So I will leave with some key messages from our experience. Number one, starting small, scaling up smartly. Number three, partnership engagement. Number four, ownership oversight. Thank you all for your attention.
Thank you, Samir. That was really interesting. Impressive to see how far you've come, but so quickly. But also, I like the fact that you, instead of just talking about the boxes, you talk about the steering committees and the working groups and the people who are actually making it happen. Yeah, very interesting.
Thank you.
Dr. Sala.
Good morning, everyone. So I'll be speaking on integrating DHIS2 into Ghana's national health architecture. So earlier on this morning, Bob said it looks as if Ghana has become of age in the DHIS2 implementation. We are senior brothers and sisters in the game. And the DHIS2 serves as Ghana's official repository for health service data and covers, we started in the year 2012, so we are a little over a decade old. And it covers now all the 261 districts within the country, and over 11,000 facilities report into the DHIS2 system. So the Ghana Health Service, through the Center for Health Information Management System, manages the DHIS2 implementation and access control within the country. And then the Ministry of Health now serves as gives the policy direction, making DHIS2 the backbone actually of reporting for Ghana Health Service. So DHIS2 aggregates both data, facility reported summaries, and also the e-tracker individual data as well. And then the frontline health workers are those that collect the data in registers and or from the DHIS2 e-tracker and then syncs upwards eventually. Then at the sub-district and the district level, so with Ghana, our health system, we run from the community level, which is the sub-district, to the districts, then the regional, then the national levels. So approvals are given at the sub-district and the district level. Then the reports are accessible to the district and the regional and up to the national level for decision making. So we are able to have dashboards and all that at the headquarters level to be able to ensure that we can make decisions with it as well. In terms of the data architecture, this is where DHIS2 sits. And of course, we have now a lot of our facilities have actually been hooked onto the electronic medical records. This is actually still in the process of being widely deployed. And then all that as well is synced into the DHIS2. We also have the GILMIS, which is for logistics and supplies health system. That also as well comes into the DHIS. Then we have the HRIMS for human resource activities as well. And then you can see the tracker for maternal and child health, for HIV, TB. And then we have other events like cause of death and admissions, outcomes, epidemiological data, all that with also the transport assets all coming into this repository in the DIMS. So this is what it looks like. And so the DIMS has become the main driver for all our health information management. And then efforts are being made to make DHIS2 a full health information exchange to ensure that we can exchange information between all these health systems that are, health information systems that are being run. So this is just like a graph of what the governance structure looks like for the DHIS2 as well. So we have, this is the central level, national level structure. And then the Ministry of Health sits up here. Ghana Health Service is an agency under Ministry of Health, and we have CHAG. CHAG is the Christian Health Association of Ghana. So we have some faith-based facilities that are being run by this CHAG, and then private facilities. And representatives of all these agencies form are in the Interagency Leadership Committee. And then they form this Information Monitoring and Evaluation Technical Working Group to have oversight over what we do in this space. Then under Ghana Health Service, this is where we have the PPMED, the Policy Planning, Monitoring and Evaluation Division, where the Center for Information Management System sits. So we have 4 units under this division. So this is the main driver for the implementation of the health information management system for DHIS2, sorry. And then the DHIS2 technical team falls under that particular unit. And we also have HISP Ghana also granting us technical support to be able to ensure that DHIS2 is running as it should. So we have partnerships both locally and internationally when it comes to the implementation of DHIS2 and running DHIS2. So HISP Ghana grants technical expertise to customize and maintain DHIS2 as we work on. The development partners have also aligned with Ghana Health Service priorities in terms of management of the health information system. So we have the Global Fund supporting both infrastructure and capacity building of officers in terms of the implementation of DHIS2. CDC supported the HIV tracker implementation. USAID HISP program assisted in community maternal and child health e-tracker rollout as well. And then we also have the PATS GIZ Digital Square initiative, which is helping to enhance immunization e-tracker and interoperability. And as you can see with this slide and all the support we have, the issues that have come lately in our system definitely goes a long way to affect with the implementation we do because of funding issues as well. So in terms of national usage, when it comes to DHIS2, DHIS2 coverage, as I mentioned earlier, is currently in all the 16 regions in Ghana, and then also all the 261 districts as well are on DHIS2. The reporting compliance is about 93%, and data quality issues. Ghana, the Center for Health Information Management System usually runs the routine data quality audits on the DHIS2 data sets, and then the discrepancies are flagged, and then the feedback is given down, cascaded down to the regional, the district, and the sub-district level as well. Monthly reporting has actually improved, I mean, with the timeliness, and it makes, instead of the number of weeks it used to take for us to be able to compile data, now we have real-time data once it is approved for decision making at the top or at the national level and even at the Ministry of Health. And the good thing about using DHIS2 is the fact that we have one source of truth. So you can tell the story, putting all the story from various programs from various areas to be able to bring together to say that this is the story line as well. And then we can compare data at every level of the healthcare delivery system. Today, all the key health programs are on DHIS2, from malaria, HIV, TB, maternal and child health. They all report through DHIS2 standardized forms as well. The dashboards are available at the regional and the headquarters level to help for decision making. And it's very interesting now that the dashboard has become a very fanciful thing for partners and for managers. Everybody seems to be saying, I want a dashboard. I want a dashboard in my office. I want a dashboard. So the dashboard has become the thing of the day. And that is interesting because it goes to say that the data culture, we are getting somewhere with it within the healthcare delivery system. Driving client-level innovations in Ghana is the e-tracker initiatives as well that we are implementing. So the maternal and child e-tracker, which tracks antenatal, postnatal, and child health services, has over 5,000 facilities on it as well. And this is going a long way to strengthen follow-ups, and actually a lot of defaulters, especially when it comes to postnatal and antenatal care, and even immunization services, has been strengthened because of the maternal and child health e-tracker. We also have the HIV and TB tracker, which has been streamlined, which has streamlined the ART management across all the clinics, and then TB surveillance, and then it reduced data entry burden. A lot of times at the lower level, there's a lot of data that people in the community or health workers in the community level have to put into the system, and especially because they multitask already. So this makes it easier. They're able to enter the data in straight away whilst they attend to the patients, and they do not have to come back to be able to enter. So that has been an addition as well to improving services, both, I mean, from the community up onto the headquarters level. And then the immunization tracker, integrating the child vaccination registry, is now operational in 7 regions. And then it also supports defaulter tracing as well. Then there's a cross-system linkage. The tracker interconnects with the maternal and child health TB immunization data, building a unified longitudinal records per patient. So you can tell about the patient's life history by just being able to get into the system, instead of us having individuals keep their own health records. We have had a lot of achievements and impact, with the impact of DHIS2 in Ghana, and that is most importantly the single source truth, where we can see the story and we can see all the related factors, the culture of data use, and then it is very important that when it comes to this dashboard, nobody wants to see a red. So When a manager just goes on the dashboard and then sees a red, then that means that you know that you are getting a call for getting that on, that being reflected in your region or in your district and all that. So if you look at this dashboard, we have various indicators that are being outlined here. So we can have the TB notification rate, that is 59.9%. We have the TB treatment success rate. And also we can have everything that we need to tell the TB story, everything that we need to tell the maternal and child story. And it makes it easier for people who are not even interested in tech and all that to visualize their issues and be able to take decisions more easily. We have had some challenges and lessons learned from DHIS2 implementation, issues around connectivity and devices, limited internet, and also the sharing of hardware as you go down subnational levels makes it more difficult, and also makes it difficult for them to sync on time as well. And then also consistent system use is actually affected. We've also had issues with parallel systems, ongoing reliance on paper and unintegrated database leads to duplication. So you still have instances where you have duplication because people are still moving from hard paper onto the system. User adaptation, staff turnover. So there's a lot of staff attrition, and you have to keep on training people to be able to ensure that you keep up with using the DHIS2. And then there isn't too much support as well as you go down the health system. And then data quality gaps, incomplete reporting, and inconsistent indicators is also because of staff attrition, because of issues around just the above things that I've mentioned could also lead to that as well. We have had issues too with interoperability, a lot of systems that are also being introduced alongside because of expectations of divisions, expectations of programs within the country, and we have to work with interoperability issue and then sustainability as we move forward. For the future directions and sustainability for DHIS2 in Ghana, we are looking forward that by 2026, all districts would have been shifted onto the e-tracker in terms of the maternal and child HIV, TB, and immunization. Electronic immunization record registry, as we'll have an electronic immunization registry, which makes it easy for us to be able to track a child throughout, and that will also be linked to the birth registry. So it makes it more and more easier to be able to track defaulters and to be able to ensure that you are building up on the person's health needs as they move ahead. Our interoperability goal to develop the health information exchange on DHIS2 to ensure that, as at least for now, the health information systems or the systems that have been deployed alongside will be able to have this exchange of data and all that, and then data use and analysis, enhanced dashboards to ensure that we be able to take decisions as well at every level of the healthcare delivery system. Thank you.
Thank you. Good. It's interesting listening to that, comparing with Maldives. That Maldives is so tiny. Ghana is. Big scale affects the agility as well.
But complexity is still there.
Yeah. Adam, over to you. I was saying before they started, the people from Togo, they're not allowed to say bad things about people from Ghana.
Bob is always trying to set me up against Ghana. Okay, good morning. Are you sleeping? Bonjour. Ça va bien? Well, I'm going to talk this morning about the current realities and the future directions in health information systems architecture in sub-Saharan countries in Africa. So first of all, before starting, I want to say that I intentionally plan to be a little bit provocative. Not much, just a little bit. And after hearing of the nice stories of the countries, I think it's also time to look at what is the other side of the interoperability of architecture that is not that shiny. So that is what my presentation will be about. So first of all, I would like to recall that the debate, the discussion about interoperability and architecture dates back to maybe early 20,000s, after the beginning of the implementation of online systems like DHIS2, OpenMRS, and so forth. And initially, there was even a failed attempt to develop what was called at that time a health suite that is comprised of DHIS2, OpenMRS, and another application. So just to let you know that the idea of failure is always around the corner. Then in 2010, HISP, WHO, the West African Health Organization, IntraHealth, organized in Ghana the first connectathon to showcase the interoperability between DHIS2, the Human Resource Management System, and OpenMRS using the standard called SDMX HD. And that was, for many of us, like a very promising era of a new era for information system architecture in our countries. And later on came other initiatives like OpenHIE, FIRE, OpenHIM, OpenFN, Smart Guidelines, and so on. And curiously, no one is no more talking about HDMS. No one is no more talking about the SDMS HD.
SDMX HD.
Yeah.
That evolved. Now it's ADX. But it's still there. Yeah.
Okay. So after 15 years of all these initiatives, where are we now? I have arbitrarily identified three main categories, just for the sake of simplicity, because you will see later on that one country can be in one category, but still exhibit elements of the other categories. So the first category is the country where interoperability is used to create order. The second category is the countries where people are doing things with the means they have in a given situation. And then we have a third category, which is more controversial, that I label as interoperability as a technical law. So for the first category, I think we have some of the countries here that are in this category. We have three subcategories. We have some countries that are in the early stage, trying to work on developing doing the foundational work, like setting the digital health policies and infrastructure. Some are in the pilot phase, and then you have some pocket of excellence. Everything is not perfect, but at least they are doing things in what we can say politically in the right direction. Then we have countries doing with what is available to them. One may call it bricolage. So the idea of bricolage here is not to say that it's good or it's bad, but if we put things in perspective, we can say that it's good because it's the best solution they have at the given time in a particular circumstance. So what is happening in those countries? Usually this happens where there's no proper governance or digital health strategy in place. But then suddenly there will be a need to address a serious problem. For instance, in the context of COVID, where all countries have to scramble to set up a system, DHIS2 tracker to manage COVID cases and also vaccination. And then came the need to have certificates for people. And then they say, oh, no, we don't want to just issue certificate like that. We need to link it with the national ID system. And so in a very short period of time, people have to do something. And then in this case, the technical people will just meet and try to do something with the limited capacity they have. And particularly in that circumstance, when you are called to do something in 2 weeks or 1 week, you cannot come and say, oh, let's set up a proper governance first. Let's develop the strategy. You don't have that luxury. You just need to go and do whatever you have at hand. So usually this is done through API to API link, or sometimes it is even just SQL queries, pulling data from here, injecting it into another system. But the downside of this, and you have seen it in some countries, is that this can lead to messing up with the metadata in one of the systems involved, because if you are running SQL queries against your database, then there is a risk, and you have seen it happening. And sometimes the downside of it is that since there is no proper governance in place, if one system if there is one upgrade on one end, or one admin is not happy with what is happening on the other side, he can just switch off the system and everything will stop. But that's life. Then the last category is the technical layer. Here too, the main characteristic is that there is no proper governance in place. So usually what happens is that you will see one partner come in with a system and start by saying, yes, we want to do, this is my system, I want to implement it in the country, but for sure, I will make it interoperable with your HMIS. So the interoperability is then used as a way to dismiss concern about duplication. And unfortunately, when they come with that idea, then you realize that there's a tension between the partner's agenda and the national priorities. And usually, the promise of interoperability is just a very narrow focus on the technical aspect of it. There's no thought of the long-term consideration. There's no thinking about doing the foundational work. They just need a quick fix. So the investment is also minimal, just to set up the technical thing, and there's no thinking about maintaining that interoperability over time. And unfortunately, sometimes this interoperability is even made between two systems that are not all mature. So even if technically the same can still exchange data and talk to each other, if the same is not mature, the data is incomplete or of poor quality, then there's no need to actually pull data from that system into the national HMIS, for instance. And this happens in many countries where you have seen, for instance, the project of a human resource management system that is set up, and then the same is not up to date. In this district, you have maybe only 10 people in the same, but we know that you have more than maybe 100 healthcare workers in that system. So why should you be pulling that data into your HMIS? So even though technically the solution is there, you don't have the incentive to do it. So interoperability should not be a matter of technical luxury, but it should be based on concrete needs, and it should be done for systems that are mature enough. So we need to think of interoperability as needs in terms of need-driven. So we need to consider where it is needed in order to do, before thinking of doing this, taking this effort. So what are the prospects? Many things has been already said. I will start with talking about capacity. capacity, human capacity is very key in this. If you don't have people conversant with the interoperability topics, so how can you expect them to come, sit, discuss, and plan this? So we really need to invest in training people, skilling the IT team, the data science people, and so forth on the topic of interoperability. We need also to work on governance. Governance is key. I'm glad that the other colleagues talk about governance, but what I want to highlight here is that there is a serious need to develop clear policies, legal framework, ethical guidelines on data sharing, data collection, privacy, security, data use, and so forth. And unfortunately, usually within the Ministry of Health, we have sometimes the one agency or department in charge of digital health, you have the HMS, and sometimes you have also the IT department. So when we talk about governance, we need to set up governance bodies that include all these stakeholders together, and even beyond. We need to talk to Ministry of Digital Economic people that are usually in charge of the government infrastructure, and also to the agencies in charge of national ID, to make sure that whatever we are doing is very streamlined across the sectors. We need also to think of value for end users, and I'm glad that Ghana has shared some examples of the excitement of getting the dashboard. So the system that we should be bringing should bring value for the end users. We need also to go for open standards and open source, because in so doing, we adopt some internationally recognized standards, and by using also the open source system, we can reduce the cost and also cost of adoption, and also foster local capacity building. Bob said this morning that when we talk about architecture, we should not think of the boxes, but we should think of what we have. So, and that it is a process. I like using the word or the verb architecting, because to stress the fact that it is a process, and we don't need to, when we have the boxes or the recommended boxes, we don't need to wait to have all the boxes in place before start working on the architecture. We need to start with whatever we have, focus on some key pain points, and then try to address, learn from it. If it succeeds, then we move to the next one. If not, we come back, try something else, and move on. And finally, we need also to focus on change management. We need to highlight to the stakeholders the benefit of the architecture. We need also to do some training, communication, and also, if needed, provide some initiative. So this is what I want to share with you, and I hope it will be a food of thought for the discussion that will follow. Thank you.
Thank you, Adam. There's a lot you can jump up. One of the things that you brought up there that didn't come up so much with the other two is you mentioned cost once or twice. And partners, some of those partners who may no longer exist. One of the things that I've seen, and not even just in the kind of typical contexts we work in, but even places like Canada and the UK, these health information architectures and interoperable framework can become hugely costly, hugely. And we'll be very wary of that when we build things that way. Best, if you're looking for global best practice seems to be to create something that's going to cost taxpayers for years and years and years to come. Jose, what are you thinking?
Morning, can you hear me? So I'm going to talk a bit about FHIR and how we can use FHIR to stimulate a couple of good things. My presentation is going to be starting from the technical perspective, so it's going to be boring for most of you. So let me start with a show of hands. First of all, who here is in this room? Show of hands. Okay, some are not. Who here, besides this week, has heard the word fire except for this week? All right. Who here has some technical dexterity or works with technical stuff? For example, you can look at the JSON file and debug what is missing, a comma missing or a quote missing. Who can do that? Who is doing that kind of work? So my presentation is mostly for the ones that did not raise their hands, except for the ones that are not in the room, but for the ones that are not in the technical business and the ones that are hearing fire, but it's not something that we do every day. I need the switch thing for the slides. Thank you. Oh, they are staying away from me. That's not a good sign. So I just, a couple of things. Sorry, this is me, but just a couple of things. As Bob said, I wear a couple of hats, but mostly I'm working with governmental organizations, non-governmental organizations, volunteer organizations, intragovernmental organizations, and most importantly, I'm dealing with the lack of organization in many of these places. So I'm advocating for fire and capacity building as well. I started giving fire trainings, but I realized that giving just fire trainings and having everyone understand everything about profiles and technical details, that's not enough. So we started working on, and I became a fire certified, they call it educator, to see how we can structure curricula for giving people the technical skills that they need. And it's not that everyone needs the technical skills for doing everything on fire. So a couple of ideas that I just wanted to reflect with you and see how we can use this, the things that fire brings, which most of you actually already have, even before the exposure to fire, and how we are looking at the value of standards and how we can use that value of standards with the things that we have already in our plate to do. So when we talk about standards, we are really just talking about how can I do my work in a way that my colleague would do it in a similar way, or I can leverage the work that has been done before. So if you talk about fire, we talk about JSON XML, all those things have been built by other people. We are talking about TCP/IP communications, we talk about RESTful services, all those things, we just sit on the shoulders of the previous giants that were doing this. So standardization is not just a magic buzzword that, oh, we have to do fire, we have to do these standards. No, it's just a way of working that we say, can we do things in a way that tomorrow someone will have a similar problem and they will still do the same things in the same way. Not only it saves us technical effort, but gives you people that are not technically working with technical stuff, but that have to manage the technical guys like myself, it gives you more of an understanding of where is this going, can we manage this, or is just a bunch of technical buzzwords. So fire is pretty much at this moment, not for me, not just a technical standard, but it's a collection of that. It is a solid foundation on technology. It is there. It is that. It has a lot of digital health knowledge, not just technology. There's lots of things in fire that you see that only people that know healthcare and have been doing healthcare IT for a long time, they could do things in this way. If you had professionals from IT doing this, it would be different. So fire has a collection of know-how, a digital health know-how. It is a very fast-growing ecosystem. So last week we had servers and servers and servers, automatically deployed servers, version compatibility. This week we have a button in DHIS2 that you click and it makes a fire specification. That's really awesome. So it's really growing thanks to the community. It's really a fast-growing ecosystem and we can leverage that. Most importantly, two things. It is a very solid and engaged community, which is the part that you already have. So you already have a community of practitioners, people that are doing healthcare IT, and you engage with each other, you exchange ideas with each other. Fire is, the biggest value of fire is that it could manage, it could use that community for the common good. So it's most importantly a community. And for us, as we are migrating to fire, it is a very good excuse. We need to do fire, great. Let's do things in a standardized way. Let's use open source. Fire is all about open source and open specifications. Let's use that. Fire is all about communities. There's a thing called the fire community process that says, if you do things, don't do it in your corner, even if you're the head of the ministry. But do this in a way that the community can participate. So fire is a very good excuse to bring all that knowledge, all that experience, not only technological, but also governance, to bring this to the picture. Another reflection point on how advanced we already are without realizing this. One of the key things that allows the FHIR ecosystem to grow so fast is actually the same thing that allows us to do trackers and modules and different things, because everything on FHIR is based on a solid metadata foundation. DHIS2 has a very good metadata foundation. That was my happy surprise a few years ago when we started discussing how can we do these things together. And I realized, thanks to Bob's initiative, like, hey, wait a minute, we all are based on metadata. So we have metadata documented. That's how FHIR works. That's why we can do all these wonderful things on FHIR. And that's how we can have the rapid increase in functionalities in DHIS2. So FHIR and DHIS2, we share the same aspect of it is metadata driven. Much of it is metadata driven, which can allow us to do things like, can we build our own our national data dictionaries? Sure we can. We have that metadata is over there. All our definitions are there. Well, most of them are already there. We have our value sets in FHIR documented. So all of that is structured in a way that, can we produce these things? We can. This is already there. It, of course, allows us to do better data management. It allows us to do things faster. And very important for me is that for example, I had the pleasure of seeing a session on metadata quality management. We can see how many of our definitions are complete, or how many of our data is actually being used, our data fields are being used. So that allows us a more objective governance. So not just setting the roles, but actually setting targets for the governance of our metadata. So this is how one of the aspects of having FHIR and DHIS2 working together to create an architecture. Because we have the systems there, and those systems use data, and that data is solidly represented as metadata, using FHIR is for us not such a distant step. We can actually use FHIR to help create that national data architecture, which for me is really, I'm really much data centric. So if we do that, then we have a chance at saying, how is the ministry handling vaccinations and TB and any analytics that we do in a consistent way. We have this problem. So I'm working from Belgium, and we have the problem of how can we do the different pilots? How can they kind of keep a solid backbone of data structures? Because we want the patient to be represented the same way, that whether it's an HIV patient or a pregnant patient or a migrant or a refugee, we want this to be consistent. This problem exists, and it's not a technical problem, it is a functional problem. So fortunately, we have metadata, and we are giving some steps on this. Speaking very briefly on the standardization journey, everyone will have their own journey. We had a standardization journey in Belgium. I just mentioned it an example. I think I have a timeline, yeah. So this is where we were 5-6 years ago. We started like, we should do FHIR. Yeah, good, that's a good idea. Where's the budget? We don't have it. Who is going to manage this? That's always a very important question for ministries. Who is going to manage this? Can we keep control over these things? The funny thing was when they realized that keeping less control, that things grew a bit faster, but still under some control. And then one of the things that we did was very early to create those communities. Not just the capacity, but create communities of engaged people, because then they trigger each other, and they go to different congresses, and they talk to each other. And I think that is the value that you already have. You already have a community that meets and shares experiences and copies the ideas from each other. Having that is, for me, much more important than just having a couple of trainings on FHIR or profiling on databases. So those are hard skills. Those we can learn very quickly. But having that community was, for us in Belgium, one of the most important aspects. And then we just evolved. So we started a HL7 Belgium, like a local affiliate that could represent some sort of open community of industry, governments, etc. And then we had a process. So that was just our flavor. We had very little budget to do things. And we said, we need to do this, but we need to do this in a way that tomorrow, if all of us leave this and someone else starts, they can still do things in a consistent way. What we did, we got together, we defined the process, and we documented that process so that everyone that follows does the same thing. There is no secret. And if you take this now to the communities that you have, I'm pretty sure that most of you will have slightly different journey depending on the resources, motivations, and stakeholders that you have. But at the end, you would end up with the same thing, which is you have a resource, you will copy ideas from the other. So you have a process, you'll copy ideas from the other people's processes, and you try to build this up, and you get more skills, more experience, and then you improve from there. So if you do that, then you are in a good shape. That's what everyone is pretty much doing. And so trying to use this to channel the demystification of fire, that's a promise that I made to myself and to Bob since we started this journey. We have, so on top there, we have a pyramid. Like the pin that's dropping there is, where are we? So we talk about standards in fire. Fire is a global standard. We have international standards like IHE, SMART guidelines as well. And then we have national specifications, and then we have project specifications. The pin there is dropping where I think most of us are. We have projects that are in a country. If you take that project to another country, maybe it will work kind of, maybe it will need adaptations, maybe it will be completely different. But we are in that level. We are not making global specifications. One of the good things and bad things about the HIS2 is that there is no central data model for everything. Everyone is doing their own thing, which is very organic, but puts us there. Now, can we do this and say we are compatible with fire? If we stay away, and this is my recommendation as a fire practitioner, if we stay away from the let's do fire for the sake of fire, if we stay away from the let's do technology for the sake of technology, if we say what is this for, who is going to manage this, who is going to use this, and can we see some benefit very early on so that we see the impact of this and we can iterate as early as and as fast as we can. If we demystify from the technology side, from the buzzword side, then I think we have a good chance at building a fire capacity. But if you build fire capacity, you are just enabling people that are doing technical specifications there. Now, what we learned is that that is really not enough. In many occasions, I have the opportunity to say, if you only know fire, then you don't know much about fire. So technical people like myself, if we only know the technical ins and outs of fire, this means that we haven't seen the value of the community and the digital health, that all the knowledge of the digital health that is there, and patient-centric care and all the social and societal aspects of this, they are built into in between the lines almost of fire and of the community. So if you enable the technical people, what you'll have, and this is my recommendation, what you'll have eventually is a power imbalance. Everything is becoming about fire. How do you define your national architecture? We have to ask the fire guys. How do you build your national data dictionary? How do you build your data exchange? We have to ask the fire guys. If you're seeing yourself in these things, something is wrong. Because people like myself, we are on the technical side, we should be very much influencing the decisions on the technical aspects, but we cannot drive those. Clinical and business has to drive this. So that's where I started adding, if you want to author things or to do things on fire, you need to have the clinical people. You have to have the terminologists, because they know that a single code going wrong or being deprecated, that can have a huge impact in your figures or in the care for people. And if you have all those people there, they're still technical people. They still do clinical analysis or data analysis, and we do the terminology analysis, but we still are not doing the overall system design for our country. So we still need the governance and the strategy. And you still need project managers, because otherwise people like myself and like others, if we have a technical new toy, then we'll get busy with that technical new toy for the sake of it. So we need project-driven approaches. So we need all of this. And at the end, all of this needs to be tested. We need a common infrastructure. We need a very solid community to keep ourselves in check and to keep ourselves aligned with the overall purposes. And for that, we have technology as an enabler, but technology is not the purpose, is not the end. So if I leave with any message that I think is useful is, from where you are now, you're already a member of a community. The greatest thing that fire has brought to this ecosystem is that community. Well, a different, sometimes overlapping community, but it is the building of a community of people that are engaged to do things a bit better, rely on what others have been doing, challenge it a bit, but build on it. And if you have this community, if you have a bit of technical know-how, that will grow very fast. And if you engage with the right people, if you start defining the roles, and if you say, this is a journey, we are not going to start with everything technical now, and then we worry about the governance. But if you build those things together, then I think your standardization, your journey for adoption will give very nice outcomes. We are looking at national data dictionaries, because this is now becoming a thing. In Europe, it's becoming a real big thing, national data set repositories. We have lots of fire everywhere. But if you look at this as a journey and see how can we do these things together, not just the technology of fire, but the community sides of fire and the underlying knowledge of digital health and the concerns about care, that is something that I think will be a much more interesting journey than just having, let's do fire. So basically, I would like to have, to just recall one presentation that I did some time ago. So this is kind of a summation of what we have. So we have our data structures, but we can reuse those data structures. We have a community. That's the most important thing. So how do you orchestrate all this? I just have a couple of ideas to finish my slides. Let's not just do fire. Let's do more with fire, so we can actually use fire where needed, not everywhere. And there are different opinions on how far you can use fire. Use the fire tooling wherever useful, like the implementation guide that we've seen from Johan, that we can create implementation guides. Very interesting for me. Let's do more because of fire. If everyone uses fire, let's use that to make our dynamic communities appear faster and be more autonomous. Let's do more because of the fire excuse, let's say, and let's do more like fire. Let's do open source, open communities, governance for wherever we need. Let's build those communities up. And as I gave this analogy, so putting this together, this is for the people that have to manage these things. It's really nice to think that you have an orchestra of technical and terminologists, etc., and you have to orchestrate them. That will take some time to create this kind of orchestra, and you might not have it available. So a few years ago, I was reflecting on this and the work that we do at Digital Square. It's not this that we are aiming for. It's more this. I don't know if you know these videos. Look it up. It's Playing for Change. It's really a nice, gratifying, satisfying video. It's basically people from all over the world, and they record each other, and they just play a very nice song, many nice songs together, because they know the tune, they know how it works, but they are doing their thing, and they don't need to be in the same room. They don't need to have all the same skills. One guy is playing the thing where you where you wash your clothes. That's his instrument. Wash rack or something. Washboard. Yeah. The other guy's playing, I don't know, some crazy instruments. Some people are playing classical instruments, and that's what we have. We have different levels of skills, different motivations, different interests, very different contexts. But at the end, if we say this is our tune, we are going for standardization, we are going for building this community. Believe me, and this is my experience after a few years of doing fire and much few years of looking at the HIS2, it's going to sound really, really nice. So I thank you for your patience, and I hope that you have a fun journey. So.
Thanks, Jose.
Sorry for taking too long. I don't.
No. Everybody's been very good, and time stuff. We are still left with 9 minutes, I think, separating us from coffee. And then there's at least a good long coffee break. So hopefully you'll come up and talk to people and ask some questions. But here's your opportunity now to maybe respond to anything that people have said. Any questions or clarifications or suggestions? Anne.
Well, thank you. This is very interesting and fascinating. I'm just going to the countries first that has always been. So my name is Eng Chus, and I'm a WHO and HIS data system focal points. What really did trigger me is at the end how different the way you do it. what needed is how the data is used at the facility, at the country. And I think that is the key point, whatever we do here. And I really like, Ghana, that the dashboard, and when I was implementing in country years ago, that also was the first thing we say, we have to design a different dashboard for different end users. So we have a different dashboard for the minister. We have different dashboards for the facility community health workers. But that is something that I think of all of the discussions that are in the presentation so far, different way, but I think that would be a common destination we want to have, which is somehow make the data talk to the right people in the right language and it's understood. And then the roles of the governance is also very important. So thank you. It is very interesting, and I think the WHO has been, different way of trying to turn the smart guy live with fires, but then sometimes we also forgot, and I really appreciate your point. It's the program work, how we should be able to drive, the needs of the implementation of the country rather than just about having some boxes ticked that we have done a certain guidance and certain technology. So, and then the ownership of the government. So this is something that, in WHO, we are currently doing some of the global data assessments. And this is also one of the key areas that has come up, which is the data governance issues, how we manage the data sharing, how we manage the standards, and the fact that how we have all different systems put together. And with Ghana, the fact that you can pull the data from different programs into the HMS. At the moment, a lot of what we are doing is we think that it is standard, it's integrated, but actually it's just digitalize a silo system into something that can talk together, but we haven't got the files to see how it can be implemented as a shared data system. So thank you. This is very interesting.
Thank you, Anne.
Thank you all. This was really a fantastic presentation. Maybe one small reflection and to kind of ask if I'm getting the point, but it seems like the whole point was this is something that you do and not something you achieve. So the architecting and the process. And it made me think about Ghana's presentation where some of this standardization seems to be happening already, even before fire. So when you presented those 3 different types of trackers, but there must have been work that went into sort of harmonizing or defining that patient profile. We know it's a mess if you don't do this in the beginning, trying to bring it back together. So one thought was, our country is actually already starting to do this, and maybe they don't even realize it. Because they're not calling it fire, but they are doing this process. But maybe also concretely to Jose, I was wondering, you talked a lot about building that community in Belgium, but like, what is that community? Who are they? How do they interact? What do they do to kind of support that journey? And what would that look like in another country?
In terms of community building, so not only in Belgium, I helped some other places set up their local communities, because at some point we need to do something. How do we do this? Get together. So the community is pretty much someone that has the mandate to start doing something, typically the ministry. But the ministry doesn't want to be seen as we will do this alone in many cases, and hopefully in most cases. So it's all about also reaching out to the vendors that are in the country or the universities, hopefully also hospitals, and then saying, basically that's what we do, like, hey guys, we are going to having a meeting, and then if you use fire, everyone is going to join. We are going to have a meeting on fire and then vaccination, and that meeting has 2 purposes, or 3 purposes, like do something, realize that fire was not going to solve the problem of vaccine codes, it's not. But by being in that meeting, you'll see what's happening and who can you contact about those things. So it's really about open meetings, so like the openness, it's open meetings for discussing certain topics. And I think it grows organically. You do need someone that says, how many of those meetings do we want to have? Do we want to have one for vaccines and one for medication? Because it's really kind of the same thing. But so how do we set the communities? In our case, we said, let's start with a logo like HL7 as a community stimulator. And we just said, can we do something on infrastructure or on medications or on vaccines? And then we just reach out, so we find the right partners in the country, say, hey, we are going to start having some meetings. Please join. The purpose of this is to create something that we understand together, and then we are going to push it up the ministry. Or in some cases, the ministry is with us, so they are going to endorse that because it's the thing that they want. But it's pretty much like start with what is your current concern? Like if the concern is fire, something is wrong. But if the concern is medications, really a hot topic, or patient summaries, really hot topic, start with that and say, can we get together? And typically the plan is we should do this in a couple of meetings, 20 meetings ahead. You are still discussing, but now you have a community. So it's like getting these things together, meetups, etc. Does that help? Thank you.
Yes, good morning, everyone. My name is Aus Kalega from Uganda. I think my question goes to Ghana, but it can apply to any of the speakers. So maybe how are you addressing the challenges of power reliability, internet connectivity, in support for real-time data entry? Because I saw that you're supporting, I think, real-time data entry for the HIV TB tracker, right? So how are you addressing the challenges of that? And additionally, how has the recent drop in funding affected these efforts? And what strategies are being employed to sustain the progress under these constraints? I hope that is clear. Thank you.
Yeah, so thank you very much for the question. So yes, in terms of internet connectivity and all that, I think that what we are trying to do now is to, there's a government-funded kind of project to ensure that every BMC, that is a budget management center, which is a facility or from the district to the regional levels, have all been connected to some internet to ensure that that is being handled. So that is a project that is ongoing. I think so far they have had about 300 facilities that have been connected onto that. So we are hoping that with that being led, which is a government-led initiative, it will be able to sustain it in terms of that aspect. And I think that it goes into the whole process of sustainability as we look at a lot of funding being cut. I think that we're actually just going into a meeting next week to really look at a lot of strategies to be able to see how much government can begin to look at how we can fund activities related to health information management system, looking at the budget cuts and all that, so that the government will be able to handle a lot of the issues, and also maybe go ahead to probably add that part of the costs to patient care, health care or something, to be able to sustain that. So that's what is being looked at in terms of all the budget cuts. And yeah. Thank you.
Yeah, I'm sure you must have interesting connectivity issues in Maldives, I guess, all the islands. Or was internet generally quite good?
Yeah, it's even though like we've got lots of islands, the connectivity is good. Like people are also on mobile. So like when we talk about the modules, there's also like mobile use by healthcare providers, so that it's the data collection is easy easy to reach at the community levels. It's relative. The government network is relatively good across the country. Yeah.
So I think we're just sort of getting warmed up, but we've run out of time. It's coffee time now, is it, Max?
It is, yes, it's coffee
So,
time.
so let's continue the discussion after coffee. I think a lot of interesting points have been brought up, which would be nice to explore further. I think particularly around the fact that Rebecca made, I thought, quite a good point that most of the stuff that we're talking about doing with fire now, smart guidelines, profiles, what have you, it's not as if we haven't been doing it all along anyway. But I think sometimes using things like fire helps us with the grammar and the words, that as long as we're in control, we can actually use it to help what we're doing. Anyway, let's go and have coffee. Thanks, everybody, and thanks to the panel.